All right, future HFAs, I have some good news for you. If you understood the foundation of Medicare and PDPM, the Medicaid section will be pretty easy. There's some overlap as far as how we get paid. If you still have some questions about the Medicare side, that's fine. Really, the Medicaid side will there are some differences, but you'll also be able to hammer home some of the concepts from the Medicare module. All right, so let's do a quick intro into Medicaid. So, Medicaid is a state program. On the other hand, Medicare is a federal program. Medicaid, you're getting money from the state. Medicare, you're getting money from the federal government. Now, behind the scenes, what a lot of people don't know is where do you think our state gets the money for Medicaid? A good portion of it is actually matching funds that they get from the federal government. But here nor there, for the purpose of this class, Medicaid is a state program, state funding. But why should you care as a nursing home operator? Well, the majority of your payer mix is going to be Medicaid, most likely. Uh, Nursing homes do serve Medicaid population quite extensively, and it's very, very common. If you look at the payer mix of a nursing home, meaning if a nursing home has 100 total residents and you just divide them into their insurance, it is very common to have 80, 85, 90% Medicaid, and that is very normal. But because of that, you really have to understand the Medicaid program, how to get paid, the appropriate utilization. It's a very important part of being successful in long-term care. All right, Medicaid payments. Let's talk about some of the fundamentals of Medicaid reimbursement. So Medicaid, when you have a Medicaid rate, that is the rate for your nursing home. So if your Medicaid rate is $250 per day per resident, and you have 100 Medicaid residents, you will receive 250 for each resident. They're all the same. Now, let's contrast that with Medicare. We just learned that with Medicare, that's not the case at all. In fact, it's quite the opposite, right? If you have 10 Medicare residents, you're most likely going to receive 10 different Medicare rates, right? That's the essence of PDPM. Not only will you receive different rates for those 10 Medicare residents, but if you were to dive into it, you will see a dollar amount tied to PT, OT, speech, nursing, ancillary. We went over that. Medicaid is actually the opposite. So if you have 100 Medicaid residents and your rate is 250, that's what you get for every Medicaid day. So how's that possible? What makes up the rate? How do you change it? That's stuff we're going to cover in this module. A couple more foundational things. The rate will change a little bit every quarter. Now, there shouldn't be drastic changes every quarter. We'll get into that. But it does change every quarter, which means you have an opportunity every quarter to improve your rate. Um, Once a year, the rate can change significantly, and that's called rebasing. We'll also get into that. We'll also talk about cost reports and specifically Medicaid cost reports. Uh, we will get into the details of it in a later module, but in order to understand the foundation of Medicaid reimbursement, we have to cover a little bit of cost reports now. And I want you to think of cost reports as the foundation of your Medicaid rate. And then case mix index scores. That is the big portion of this module. We're going to get into what they are, the resource utilization groupings that they correlate to, and that will be your assignment to understand and calculate some CMI scores. Okay, your Medicaid cost report. I could do a whole class on cost reports. I doubt anyone would take the class, but my point is it's a lot of information. We'll dive into it a little bit deeper in a later module, but for now, we need to start with the basics of it so we can understand what makes up that Medicaid rate. So, first question, what is a Medicaid cost report? Look, every provider in the country that wants to bill Medicaid and Medicare has to complete cost reports. You have a Medicare cost report, you have a Medicaid cost report. Let's throw the Medicare cost report aside. We're not going to focus on that. But let's look at the Medicaid cost report. If you want to bill Indiana Medicaid from a home health agency to a hospital, you have to complete a cost report. So, what is it? Well, lucky for us, many times the name of something in healthcare uh, is pretty self-explanatory. A Medicaid cost report is a report where we put all of the cost of that nursing home and we give it to Medicaid, and that's it. Um, the way I want you to think of it, and this is actually the analogy that I use at work, and I'm actually meeting with a potential client this week to go over some of this stuff. The Medicaid cost report, think of it like buckets, okay? And at the end of the year, a nursing home has all of these costs, right? They have to pay people, they have supplies, all of this, and these costs go into these buckets. And the buckets are called components on the cost report, and basically they're just categories that tell nursing home operators how to allocate their cost. Doesn't tell them what to spend or how much to spend or where to spend, but it tells them, hey, if you buy this, if you spend this, it has to go in this bucket. And I bet you guys could probably guess the components or the buckets of a Medicaid cost report. What are some common, obvious expenses of a nursing home? You have nursing staff, right? Nursing supplies. You have gloves, briefs, medication, things like that. Guess what? That would go into the bucket, the component of direct care. That is a direct care cost for that nursing home. Another bucket is called indirect care. And you could probably guess that would be your routine staff, your dietary department, your raw food, your dietitian, things like that. And you have these buckets: direct care, indirect care, administration, capital, therapy, things like that. These buckets are nothing more than cost allocations. And that, in essence, is your cost report. Now, the next question is why, right? Why do Medicaid providers have to report their cost in a standardized way with these buckets? Well, um, to me, this is one of the most interesting questions because we've already discussed that your payer mix, you may have 80% of your population maybe Medicaid, okay? Maybe 10% is Medicare. In our world, in long-term care, a huge part of your revenue is Medicare and Medicaid. Very, very little is private or private insurance, right? So where does that funding come from? It's our tax dollars, right? That alone is enough justification to say, hey, if you're receiving Medicaid funding from the state, we deserve to know what you're spending, how much you're spending. All right, where's it going? Um, it's our tax dollars at work. Cost reports require transparency and standardization of nursing home cost. Let let's look at you got to remember, these nursing homes are owned by people, by corporations, okay? We need transparency. We need to understand uh, where their cost is going, how much, and we need to know that in relation to other nursing homes. Um, let's take an extreme example, okay? You have a nursing home and it has an owner. You would not want that owner to buy vacation homes and yachts and go on extravagant trips and then say, yeah, that was a direct cost of my nursing home, right? That's an extreme example, but I think it hammers home the importance of these cost reports. Also, let's look at it look at it from a relational perspective, okay? You've got two nursing homes. You have one over here that spends $2 million a year on direct care. Their direct care bucket, that component, is $2 million a year. Okay, and direct care, as we know, would be nursing, RNs, LPNs, QMAs, CNAs, nursing supplies, gloves, briefs, things like that. Okay, and then go over here, and you have another nursing home, same size, maybe even the same town, and they only spend $1 million a year on direct care, the direct component, nursing, things like that. So right away, we can make some common sense assumptions about these two nursing homes. One is spending about $2 million a year on direct care. One is spending half that. Which one do you think provides better care? Which one do you think is doing a better job of taking in that Medicaid money from the state and then using it to take care of their patients? Clearly the one that's spending more. Now, another extreme example, but I think it again hammers home the importance of these cost reports. Okay, so we've unpacked a lot there, but the main thing that I want you to take away from this slide with cost reports is all Medicaid providers have to do them. They are nothing more than a big report where we have these buckets of cost, and they are the foundation of what makes up that Medicaid rate for that nursing home. All right, so if the Medicaid cost report is the foundation of our Medicaid rate, then what's the windows and the frame and the drywall and the roof and things like that? Well, insert CMIs and rugs. Now, this this will look very complicated at first, but then once you get it, it it's not complicated. The CMI, case mix index score, and the RUG, the resource utilization groupings, are saying the same thing just from different perspectives and probably from a different discipline. Okay, so let's look at CMI first, then we'll look at RUGs, then we'll see how they correlate. CMI, case mix index score, it's important to know that every post-acute care provider has, whether it's a CMI, maybe they call it a CMA, like in home health. It's a way to quantify what the resources required to take care of that resident's specific needs. So let's look at an extreme example. All right, underneath the case mix index score column, the CMI can be any number between 0.45 and 3. 0.45 is the lowest CMI score, 3 is the highest. Okay, so let's pretend that we have two residents in the same nursing home. One has a 0.45 CMI, one has a 3 CMI. If we assume that the assessments were done accurately and those CMIs are correct, then without even knowing the patient or knowing anything, we know that the patient who scored a 3.0 has a lot more going on than the patient who has a 4.5 or 0.45. When I say more going on, I mean their acuity. What is going on with that patient? What resources does it take for that nursing home to care for that patient and what they have going on? A patient who scores a 3.0 has a lot going on, high acuity. Maybe they are very sick. With a 3.0, maybe they're on a vent. Now contrast that with someone who scored a 0.45, the lowest CMI. They probably don't have a lot going on. They're probably completely independent with their activities of daily living. They can ambulate just fine. They do not need and are not receiving any therapy. They probably don't need to be in your nursing home if they're scoring a 0.45. But my point is, the CMI is nothing more than a way to quantify the acuity of your population, quantify the resources that it will take from your nursing home to effectively meet those patients' needs. Okay. Now let's move over to RUGs. Now RUGs, were synonymous with Medicare reimbursement pre-PDPM. Now, astute operators know that RUGs are still a very big part of what we do. So from the perspective of Medicaid, RUGs are nothing more than the categorical side of the CMI. Every CMI over here has a RUG category. It is one in the same. It's simply a different perspective, a different way of approaching that category. A lot of times your financial people will speak in CMI, right? Our blended CMI is 1.22 on a state average of 1.25. That means that our blended acuity is lower than state average. The clinical people often speak in the RUG categories, okay? HB1, things like that. It's one and the same. So I actually created a proprietary tool to train my MDS coordinators back when I was running nursing homes to correlate the two, to connect the dots, because they were one and the same. And when you understand one, you understand the other. They go together. So let's look at another extreme example, and I think it'll help understand why we have these CMI scores and how does it impact what we get paid. So let's go back to two extreme examples, okay? We have our 100 resident nursing home, and let's say on an extreme example, every single patient in that nursing home has a CMI of 3.0. That means they're all got a lot going on. The other nursing home, another 100-bed nursing home, maybe in the same town, all 100 of their residents score a 0.45. Two opposite ends of that spectrum. Well, which one? We just talked about how a patient with a 3.0 takes more resources from that nursing home to provide care. Well, we have 100 of them over here, and then over here we have 100.45. Which one do you think needs more Medicaid funding? Obvious example, right? Well, that's where the CMI comes into play, because you got a nursing home over here that is taking care of a lot of really, really sick people. They need more funding than a nursing home that just accepts people that walk or that are fine. They're independent, right? That's an example that would never happen for a variety of reasons. But let's look at maybe a real yet simplified example of how the CMI plays a role into how much we get paid by Medicaid. Let's go back to our lovely 100, I need to name this nursing home, our 100 resident nursing home, okay? Let's say that we have 100 residents, they're all Medicaid, and 90% of those Medicaid residents have a RUG of HB1, which equals a CMI of 1.22. 90%, 90 of them. Then the other 10% are all RUG PA1, which is a CMI of 0.45. Okay? Now, that's not as extreme as everyone being a CMI 3.0 or everyone being 0.45, but you can see the mix of your CMI there, right? 90% are scoring 1.22. Only 10% are 0.45. So how does Medicaid know what's the blended CMI for that nursing home to help understand how much should we pay that nursing home? Well, insert weighted average, and that's what we're going to get into to calculate that so the state knows, hey, this nursing home has a lot of complex patients. We need to give them more funding, in essence. Now, one last caveat, because I think it's important. We unpacked a lot on this slide. CMI scores correlating to a RUG score. Every patient has one. It determines their acuity, what's going on, determines the resources needed to take care of that patient's specific needs. How does the state know the CMI for all 100 of your residents? Insert MDS again, just like we talked about in week 1. That MDS assessment is how we get the information that we're doing for this resident to the state so they can quantify a CMI. All right, so let's visualize this connection between CMI scores, RUG categories. How do we get there? What's going on with the patient? Okay, so this is one row of a table that I created years ago to help quantify that connection, to help visualize for my MDS coordinators as well as the CPAs who worked in billing and in the back office, to help them understand from the financial side that these are people, these are residents with stuff going on. They're not just a CMI score. And then from the clinical side, to understand that this isn't just an arbitrary group of letters. This quantifies things, right? So let's look at it, and we're actually going to work from right to left, okay? And then we'll go back. So on the far right, CMI. That's that 1.2 that we've been using as an example. This patient has scored a 1.22 with their CMI. Move left, one column. Well, what is that 1.22? Well, that 1.22 is a RUG category of HB1. Okay, there's a connection. That means if you have 100 residents that are in the RUG category, HB1, that means you have 100 residents that have a CMI score of 1.22. Pretty simple. Move left again. This column is called end splits. Now, we're not going to get into it too much here, but I didn't feel like it would be appropriate to omit it from the tool. The end split basically looks at some of the mental issues of a patient, mostly depression. And basically, let's do a very simple example. All right, we have two patients. Both have a RUG code of HB1, meaning CMI of 1.22. We think they're identical. They're clones of each other. However, this one has signs of depression. This one does not, thank goodness. Which one do you think would require more resources from that SNF to care for? Obviously, taking care of a patient who is clinically depressed will require more from your staff, right? Therefore, in this example, this row, let's say instead of the end split saying no signs of depression, it would say signs of depression. Well, guess what? That would be a different RUG code, maybe HB2, and it would be a higher CMI, maybe 1.24, 1.25. The end split, again, helps quantify basically the resources needed if someone's depressed. It's a little bit higher of a CMI. Let's go left one more to the ADL index score. I think probably by now you guys are, or at least have heard of ADLs, activities of daily living. Basically, it's again a way to quantify the physical independence or dependence of your residents. Let's go back to our example here, side by side. We have those two same residents. They're clones of each other. Everything is identical across the board, diagnoses, everything. However, one maybe just had a hip replacement, and they are very dependent. They need a lot of help getting up from their bed to their bathroom. The other one is completely fine, can ambulate just like you or I, right? Okay, well that again is going to impact the resources required from your nursing home to take care of that patient. If you got a patient, does that patient need no one? Does he need no one to ambulate to the bathroom, down the hall, to activities, whatever? Do they need one person to standby assistance just in case they become unbalanced? Do they need one person to actually help them physically? Do they need two people? Are they completely dependent? Those are very different situations that require different resources from your nursing home. So the ADL index score quantifies how much help that they need. A higher ADL score means needs more assistance. Therefore, just like the end split of depression, you've got two residents. One has an ADL score of 10, one has an ADL score of 5. The one that has an ADL score of 10 is going to take more resources to care for. Therefore, we should have a higher CMI. Going left one more, would be the documentation requirement. Now, this tool is actually an audit tool. That's why it references documentation requirement, because it's showing what we have to have documented to justify that RUG category and therefore the CMI. But for purpose of this class, what I want you to see is that that little cell right there quantifies what's going on with that patient that determines the RUG code and therefore the CMI. So if you had the full form will be attached in this module, and you'll be able to see that based upon what's going on with that patient, like for example in this row, maybe they're comatose, maybe they're septic, maybe they're insulin dependent diabetic, maybe they have the injection 7 days a week, maybe they're COPD with shortness of breath while lying flat, maybe they have pneumonia, weight loss, vomiting, all the stuff going on, right? If you have a patient that has that stuff going on, you connect the dots with their ADL score and their in-split, and you get the RUG category, you get the CMI. And then the first row is just basically, hey, what category is this? And category not RUG, but like category 1, 2, 3. I mean, it's just basically breaking down like, oh, that person is a category 3 special needs high type of thing. So that right there, in essence, is everything related to the CMI and the RUG. And within your assignment, you'll look at the actual tool, and you will do some research. You will say this person has COPD with shortness of breath while lying flat, and they have an ADL score of 5. What is their RUG code? What is their CMI? All right, so we have unpacked a lot about the Medicaid reimbursement, how we get paid, the foundation being the cost report, the CMI is quantifying acuity, its correlation to a RUG. We've unpacked a lot, but let's take a moment to step back and really hone in on how is this an operational tool? Why do we need to know this when we start running nursing homes? Well, I had a previous example, the extreme example, where you have 100 nursing home, you have a 100-bed nursing home, you have 100 patients, and all 100 have a CMI of 3.0, or all 100 have a CMI of 0.45. Well, that's an extreme example that would never happen. The more realistic example would be you have 100 residents and 90% have a CMI of 1.22, and the other 10% have 0.45. Now, if you have 100 residents, you're not going to only have 2 CMI categories, but the point is, how does the state quantify that CMI, which impacts your rate? How do they do that when every single patient may have a different CMI? Well, there's 48 CMI categories, and if you have 100 residents, you could very well have 48 different CMIs. So but if every nursing home, if your nursing home gets your Medicaid rate is $250 per day, and that whatever your Medicaid rate is, that's what you get per patient per day, every day for that quarter for your Medicaid population. But how? Because you have different CMIs, right? Well, the CMI is then blended together utilizing a weighted average, and it's a little more it's pretty complex, but for the purpose of this class, we need to look at how do they calculate a weighted average to get to a blended CMI. All right, so input weighted average, right? In our example, we had 100 residents in our nursing home. Let's say we have 48 different CMI scores. How do we get to a blended CMI that will impact our rate? Weighted average. This is very similar to your assignment that you're going to do. You're going to calculate a weighted average. You're going to calculate a CMI. You're going to see how it impacts your rate. So This is a small example, a simplified example to understand how the calculation is done. On the first column over there, we have residents, okay? Let's do red. We have our residents, A, B, C, and D. 4 residents, okay? Medicaid inpatient days within the quarter. This is critical, right? Think about it. Say you have 92 days in that quarter, and you have a patient with a CMI of 3.0, the highest CMI that there is. Maybe they're on a vent, all right? And they're in your nursing home all quarter, all 92 days. That's 92 days of a patient with a 3.0 CMI. That's a lot of resources from your nursing home that's needed to take care of that patient. Let's contrast that with an opposite example. Let's say that resident that scores a 3.0 CMI, that they're on the vent, let's say they're only in your building for 5 days in that quarter. It's very different, right? You're taking care of that highly complex patient for 5 days as opposed to all 92 days. Therefore, the resources needed to take care of that patient for 5 days is a lot less than 92 days, right? In essence, that's where this weighted average comes from. We have to look at the days that the patient was in the building to understand, how the resources really did it take that quarter to care for that patient, okay? So then we have the RUG, again, just the category that categorizes that CMI, which quantifies the acuity. And then over here, you have the main point of how to calculate this, all right? Let's again start from resident A. That resident is with us for 92 days, all quarter long. Based upon their MDS, they have a RUG of CA2. That RUG equates to 0.72. So when we want to try to quantify the resources needed to take care of that resident for the quarter, it wouldn't make any sense to just put 0.72, right? We have to figure out a way to weight that. So it's the days for that quarter times that CMI gives us the weight of the resources needed to take care of that patient. And that's what you would do for every single Medicaid resident. Now, a lot of this stuff is done in the EHR system. It's a little bit behind the scenes. You would need to be a very astute operator with a good utilization department to dissect this down. But that's what you have to do if you want to understand your CMI and the weights and how it correlates to getting paid. So in your assignment, you'll have a table and you'll have residents, and they will all be in the building for different days of the quarter. They will have different RUGs correlating to a different CMI, and you're going to calculate that weight. So how do you do it? Well, you do the weighted each one individually, and then at the bottom, you have a total. Total inpatient days for that quarter, meaning the sum of resident A, B, C, and D. How many days were they in? They weren't all there all quarter. If they were, resident A would be 92 like it is, B would be 92, C would be 92, D would be 92, but that's not the case. Resident C was only in the building 64 days of the 92-day quarter. Resident D was only in there 34 days of the 92-day quarter. So the total inpatient Medicaid days of these 4 is 282, okay? Well, so then let's look at the weighted score. Well, the sum of the weighted score is 271.96. All right, so what is our weighted average? What is our CMI? Well, 0.96. Let's contrast that with a simple average, a non-weighted average right here. I am sure everyone taking this course could do a simple average, right? You can add them up, divide by the number that there are, or you can do equals on your Excel, equals average, highlight the cells you want to average. So if you look at the non-weighted average of these CMIs, you get 1.10. That's a lot higher than the weighted average. So you can see understanding the weighted average is critical, because if you don't, you can see resident D, who's only been in there 34 days for the quarter, but does have a really high CMI, doesn't necessarily have as much weight on your total score. Weighted averages are pretty important and can be used for a lot of things other than just within healthcare. And I've always been surprised by how many people don't really understand the concept of a weighted average. But once you do, it does help out tremendously. All right. So why does the weighted average? What's it matter? I remember when I was learning this stuff. I remember thinking. I remember where I was in Indiana Wesleyan. I was taking a specialized course in healthcare administration, and I remember thinking, "Boy, that's a lot of work for a very small difference, right?" Um, because this table is the same. The weighted average 0.96, the non-weighted is 1.10. That is a pretty small difference. At least I thought. So why does it matter? Well, because we're working in a world where a 0.01 difference is pretty significant. Okay. And it matters because if you have, again, extreme example, if you have a building full of 1.10 versus a building of 0.96, with a 0.01 being a big difference, that is a very different perspective of the resources taken or needed to take care of the residents. Very different. Another assignment you'll have in this module is to quantify that difference based upon some given assumptions, given variables. So, for example, the difference between the weighted average and the non-weighted average is 0.14. Again, outside of the crazy healthcare finance world, 0.14 is not that big of a difference. But in our world, for every 0.01 difference, that can equate to 70 cents per patient per day. Again, go back to your Medicaid rate. We're getting $2.50 per day for every Medicaid resident. Okay. Let's say that you're operating a building and you feel like that your residents are way more complex than what CMI was being kicked out by their MDS coordinator. And you feel like, you know what, we need to more accurately do our MDSs, therefore we need to more accurately get reimbursed for what we're doing. A 0.01 is a big difference. So in this situation, you've a 0.14 difference, that is 14.01 changes, which now this would be the assumption that you're given. It varies building to building, but it could be 50 cents per patient day, 70 cents per patient day. I've seen 80 cents per patient day. So if you were able to, if you got this wrong and used just a non-weighted average, you could really significantly negatively impact any type of Medicaid reimbursement estimate you're doing based upon changing your CMI quarter by quarter. So if you wanted to annualize this difference, the 14.01 differences at 70 cents per patient per day, another assumption, let's assume you have 25,000 Medicaid days that year. All right, so that little mistake of using the non-weighted average instead of weighted average is a six-figure mistake. That is how a 0.14 difference can equate to six-figure dollar impact. Let's unpack that one more time because it's a lot. We'll go down. So between these two numbers, your weighted average and your non-weighted average, it's a 0.14 difference, okay? Let's quantify that. Let's say you're doing an estimate on your Medicaid rate and you're projecting through the end of the year and you're projecting Q2. You pull all their nice reports. You're like, I know how to do this. I got my degree. I can do this. And then you make a simple mistake. You just take the non-weighted average of your patient's CMIs. Well, you should have taken the weighted average. That's a 0.14 mistake. Well, how many 0.01s are there? Because for every 0.01 change, you were given by your RDO, that's a 70-cent PPD swing. So for every 0.01 within that 0.14, which would be 14, that's 70 cents per patient per day. Well, you've got 25,000, projected 25,000 patient days for the year. That's a $237,000 hiccup. That's more than a hiccup. That's a big deal. So in your assignment, you'll have an Excel spreadsheet, and you'll have similar instructions over here on the side, and you'll actually do that. You will quantify an increase in your weighted average CMI. All right, so your assignments for this module, you do have a little bit more to do than usual, I would say, but I think you'll find once you're doing them, although it's 3 different assignments, they're kind of the same because you're doing the assignment from the different perspectives that we talked about, right? The assignment is you're going to do the CMI perspective, okay, then same information, do the RUG perspective, okay? So first, you have your voice thread of the week, thought of the week that we always have. Second, then you're going to have your Medicaid RUG assignment where you'll be given these very short, simplified bios, like 82-year-old male presented to your nursing home with pneumonia, ADL score of 2, not depressed, and you'll have to take that short bio, go to the tool, and just like we looked at in this PowerPoint, and look at the categories, try to find, okay, I know he's got pneumonia, I know he has an ADL score of 5, they're saying that he has signs of depression. I think that the CMI and RUG is here. You also have an assignment on the Medicaid CMI weighted average, just like we did in the short example here. You'll have an Excel spreadsheet, and you need to calculate the weighted average for your nursing home's CMI based upon the inpatient days for their residents given, and then their individual CMI score. And then lastly, probably the most challenging is you're going to try to quantify in dollar amounts a change in your CMI. Because remember, the CMI, your Medicaid rate, is a quarterly rate. It changes every quarter. It's going to change based upon changes in your CMI, right? So if our example here is you're getting $250 a day, that's your Medicaid rate for Q1 for all your Medicaid patients. Well, what could it potentially be if in Q2 your weighted average Medicaid CMI goes up by 0.09, right? That's something that's a real exercise that operators do because we want to make sure that our CMIs are accurate to our population. We want to make sure that the utilization is appropriate. So we look at it and say, you know what, I actually think that we have a little more acuity going on than we're giving ourselves credit for. And I think that in Q2, our blended CMI, our weighted average, is going to be about 0.09 higher. This is how it will impact the finances. So it's not an easy one, but it is a real one. And as always, if you have any questions at all, don't hesitate to reach out to me. All right, guys, so that's Module 3, Medicaid Reimbursement. We unpacked a lot in this module. We did. It's a lot of information, but it's a lot of important information. And although I do think it's a challenging module, at the end of the day, a lot of people don't understand the complexity of how nursing homes get reimbursed. And this module takes a big step in understanding some of those complexities. So as you're working through your assignments, as always, do not hesitate to contact me. You can text me anytime. You can call me. You can email me. Just reach out. We can fire up Zoom. We'll go through it together. I'm here to help. So if you need me, just reach out. All right, future healthcare leaders, that is all for this module. Please comment below. Let me know what your thoughts are. Let me know if there's a topic that maybe we need to cover that I can add to our coursework. Also, let me know if there's something that you think is maybe off base and we need to change up. Until next time, I'm Brody09s.